There are several factors that we should consider when we think about tailoring management for inflammatory bowel disease. These include patient-specific factors and disease-specific factors. Patient-specific factors might include a desire for pregnancy or perhaps patient preferences. Disease-specific factors might include the presence of perianal disease or fistulas, also whether the patient is using the medication for post-op prevention after Crohn's disease surgery, or if there are extraintestinal manifestations, because many therapies are approved for both Crohn's or ulcerative colitis and an extraintestinal manifestation such as sacroiliitis or rheumatoid arthritis or psoriasis or others such as multiple sclerosis. So when considering which therapy to choose, we need to understand the patient's risk profile, their preferences, and the specific disease condition in order to select the most appropriate therapy and tailor it to the patient's needs. When we consider guiding principles for therapy and therapeutic management of inflammatory bowel disease, there's one overarching principle that is most important. It's not which medication are we going to choose, because we don't have a perfect medication that works 100% of the time in every patient with no adverse events. That doesn't exist. But what is most important is that whatever therapy the patient is being treated with, we have a plan. The plan is to assess the patient early for clinical response, usually within 8 weeks of starting therapy, then to reassess them after 2 to 3 months in order to determine that there's biologic improvement in fecal calprotectin or CRP and ongoing clinical improvement, and then to look for structural improvement on colonoscopy or imaging such as CT or MR enterography or small bowel or colonic intestinal ultrasound at usually between 6 and 12 months. And by having a plan and discussing that plan with the patient, whatever therapy the patient is being treated with, we will determine if the medication is working, if the patient is tolerating the medication, if there are side effects, and that we can change the course. We can adjust the dose or perhaps change the therapy if the patient is not meeting those targets. So what's most important is practicing in a treat to target paradigm where we consider not which specific medication, but an overall approach to how we consider treating the patient by making sure that we are reassessing the patient at the appropriate time points and having a plan that we discuss with the patient at the beginning of their treatment journey.